appropriate use of spinal injections, in particular intradiscal PRP therapy, would also stimulate similarly vigorous thought and questions, and hopefully also find some answers to your questions in this conversation. Part of the reason why this topic came about was a recent work that I was privileged to be a part of that just got published in the PM&R journal on de-implementation of low-value treatments in low-value interventions and treatments for managing chronic low back pain. And what I mean by low value is that there is not a whole lot of evidence supporting that they are useful, and there actually may be evidence supporting that say that they may be harmful. So there needs to be an intentional approach that all of us should take as clinicians in PM&R to evaluate which are those interventions that you think are low value that you should consider intentionally de-implementing, like getting rid of that from your practice if your situation demands it. That intentionality is oftentimes hard for us to think about or adopt, and not as easy as how we add new things to our practice. It is a lot easier, we think, when we are exposed to something new, something shiny, something that has emerging evidence bases. We want to be a quick adopter, but we don't use the same approach and process in order to be adopters. So hopefully this will stimulate some thought in your mind as to how you would consider, if necessary, if you feel like you're on the anti-side of this debate. Hopefully the speakers will inform you of what they think is the right side of this debate, and hopefully you'll be able to make your own thoughts. And if you do conclude that you need to de-adopt it, hopefully you'll have a framework to kind of consider doing so. If you feel like you need to adopt it, hopefully you'll find this debate very stimulating as well. So with that, I will introduce the speakers. It's my privilege and honor to introduce Jay Vallabh from the Ohio State University, Department of PM&R, and Minash Tiwari, who used to be at the Ohio State University, but not anymore. He is in the Shirley Ryan Ability Lab, and they will take the opposite sides of this debate. Without much further ado, it's my pleasure to hand this mic to Jay.
So, our kind of first thoughts, just a little background on when we talk about appropriate use of spinal injections. I mean, so many procedures came to mind, actually. Cervical transforaminals, epidurals for severe spinal stenosis. These things have different risk profiles, different outcomes, and so we were really trying to figure out, what is something that is kind of emerging that a lot of people might be interested in getting into, and a lot of people are already doing. All you have to do is Google it, and you can see practices in every state advertising it very heavily. And so what is kind of the evidence behind this? And so just a little bit of background. No relevant financial disclosures from either of us. This discogenic low back pain is one of the hardest types of back pain to treat. We've tried to burn discs. We've done corticosteroid injections in the disc. We have the idea of discovertebrogenic pain, or discovertebral pain, which BMA is trying to work through. And so it's just, the diploma has said it's one of the most common reasons of having back pain, and that's been published. Yet we don't have really good validated therapy to do this. Like if someone has facet joint pain, we know lumbar medial branch radiofrequency ablation, we know those responder rates, we know what responder rates are if you do 1 block or 2 block. It's very well written out, but for disc pain, we just don't have this type of therapy. And so just for some of the residents, what is discogenic back pain, low back pain mediated by the disc? How do we diagnose it? Well, we can diagnose it clinically. Probably the gold standard of diagnosis of disc pain is still propagation discography. And that also has been hotly debated. IPSIS has some clear guidelines on how to reduce false positive rates with discography. And then we talk about PRP. This is really emerging therapy, mostly used in musculoskeletal sports medicine. Many of you might have seen a really good review, in my opinion, this morning by several sports medicine docs with PM&R. Just in general, you're spitting blood and you're separating out the platelet-rich plasma, which is high in growth factors, and we're trying to regenerate cells. there's some role in leukocytes as well as far as inflammation, and that's been studied in a lot of sports literature. Do we need leukocyte rich? Do we need leukocyte poor? Should we activate these? Should we not activate these? There are a lot of questions around PRP that are still, our sports colleagues are debating, and so how does this pertain to what we do in spine? So one thing, as far as PRP, is this a therapy that we should adopt? And then discogenic back pain, how do we treat this well? And this is just kind of reviewing some protocols in PRP. Some protocols say we need to limit medications. There are protocols in sports medicine that exist as far as timing around injury. How does that pertain to timing around disc injury? Does that matter? And cell counts, what kind of cell counts matter? How many billions of cells per milliliter do you need, or how many billions of cells do you need to inject into a joint for it to make a difference? And so just a little bit of background, and Dr.
Okay, so now I'd like to talk just again, Dr. Vallabh has touched on many of these points already, but from a just basic science and fundamental standpoint, we all are probably at least somewhat aware of the use of PRP in peripheral joints, in particular with knee. I think it's been pretty well studied and is a fairly accepted modality of treatment. The core difference with PRP compared to, let's say, steroids or many of the other treatments that we offer is that it's the regenerative medicine, which is the buzzword that you may frequently hear associated with these types of treatments, in the sense that not only are they hopefully curative or very helpful for pain, but that they are addressing the underlying problem. One of the attendings I used to work with used to say that, compared to, let's say, a steroid injection, if there's damaged tissue, damaged cartilage, what has happened is that the cells have come in, they have laid down scaffolding for a building, and they've suddenly left. The funding for the project has run out. PRP being an idea that it allows for new and productive healing of an existing injury. So again, as opposed to steroids, which are perhaps degenerative themselves and don't offer that advantage, PRP being something that can again allow for tissue regeneration. The reason I mention this is that if we're treating disc pain, we know that discs hold a similar molecular, biological, chemical structure to many of the other types of collagen in our cartilage in our bodies. And so PRP should have, at least in a theoretical manner, the ability to help heal these types of issues. So I'd like to first begin by presenting a few slides regarding the evidence that is in favor of use of intradiscal PRP. The first one that I'll mention here is titled Lumbar Intradiscal Platelet Plasma PRP Injection, and it's a prospective double-blind randomized control study. It was published in 2016 in the journal of PM&R. Again, it's a prospective RCT. The inclusion criteria were adults with chronic moderate to severe discogenic pain that have failed conservative measures. And they were randomized to a intradiscal PRP or contrast only after diagnosis with provocative discography, which can be controversial in and of itself, as Dr. Vallabh had mentioned. We have 49 participants in this study, so 29 and 18 respectively for each cohort group. The impressive findings, I would say, within this study are that there were meaningful, I would say, decreases, although not statistically significant in each category. But in terms of, in particular, your recurrent pain score, best pain score, these, as you can see here from the, in the best pain category, there's a statistically significant decrease in their level of pain that was sustained at the 6 or 8 week period. And so, again, this is a promising result, right? It's showing that compared to at least a placebo, this is an effective treatment that is helping people. This study was then extended to 1 year. And again, you can see that in most of the categories here you have, or many of the categories at least, you have a statistically significant decrease in measures, everything from SF36 to the best pain score, sustained at a 1 year time parameter. The next study that I'll just briefly mention again and go through is the safety and efficacy of orthobiologic injections for discogenic chronic low back pain. This was a prospective, multi-center, randomized control study. Again, this was interesting because the patients were randomized to PRP and bone marrow injection, and then they were crossed over, which I'll explain in just a moment. So again, this is a kind of overview and breakdown of the study. So you have, your demographic information, the number of patients that were treated, and then at the very bottom here, you can see that the amount that were crossed over. So the results from this study, they actually do show that chiefly there was a statistically significant improvement in their NRS pain score, and that was sustained at the 12-month marker. Again, this is building a pattern here. We're seeing that we're injecting this PRP, we're diagnosing the patients with discogenic pain, and we're seeing improvement in their pain scores at a year, which again, for those of us who may do these injections on a regular basis, I mean, I usually counsel patients that, we hope 3 to 6 months for an epidural steroid injection, but we're looking at the time mark of a year, which I think is a very meaningful thing. I think this is going to be touched on later, but I will mention that raw scores were not available in this study, so they gave us these nice graphs, which again, we take for word as being statistically significant. Similarly, there was a overall improvement in their NAS pain score. This is kind of the same thing. And interestingly, the reason I wanted to bring this one up is that in the BMC group and the PRP group, there was actually no difference in the quantifiable amount of decrease in pain. So you can see the blue is the BMC and the orange is the PRP, but they're essentially saying here that both categories did have a sustained pain relief that was at least statistically meaningful, okay? And then the final study I'd like to go through again is, this is probably, at least from the literature review I was able to complete, the most long-term study. So these are follow-ups from patients that were previously injected with PRP at the 5 to 9 year mark. Just to go through it, so essentially this was published in the Journal of Regenerative Medicine 2019. It's follow-up from one of their previous studies for PRP for lumbar discogenic pain. There were 29 patients total. The one thing that I will mention is that although they say that there is a 5 to 9 year period, they did not specify whether it was 5 years and 1 day or 8 years and 364 days. The data is essentially pooled into this cohort. But again, we are seeing this continued pattern here that patients are achieving, and again, very impressive, at a 5 to 9 years. I don't think that there's any conventional injection, whether it's a RFA, whether it's a steroid injection, that we're saying that can provide sustained pain relief at a 5 to 9 year mark. I think this is quite meaningful. If you can, even BVN or what have you, the data is so mixed, but this is at least one study, albeit in 29 patients, that's showing what I feel to be a very reasonable amount of promise for this type of injection, and to say that it can, going to my first point about the possible, or at least theoretical predicted regenerative capacity of these injections. Again, so we're having 5 to 9 years. I don't think that simple pain relief or masking of inflammatory markers would necessarily explain this, but again, that's speculation on my part. Similarly, again, so we have in addition to the pain score, a meaningful change in the SF-36 as well. And that's just a summary of the findings. So the biggest thing here is that I will mention, the confidence interval does go through the number 1 for the current NRS and best NRS. Again, although these were able to achieve statistical significance, the confidence intervals do cross 1. And so it's a meaningful finding, I think, but we have to take some of these statistics. On the other hand, the SF-36, which again, function being as meaningful to many of our patients as pain itself, those do show that, again, with the confidence interval not crossing 1, that there were improvements at the 5 to 9 year mark, okay? So I'll hand it off to my colleague, Dr. Vallabh, who will take it from there.
All right, thank you. That definitely reviewed the positive findings that are out there, okay? But I think how many people do intradiscal PRP here? How many people want to do intradiscal PRP here? Okay, that's good. So we're starting off on the right foot, I think. So I think the first questions what I ask when I look at these papers is MCID enough? Who thinks MCID is enough for their patients? Right answer is good. Okay, right? Most people, I think, are going to.
Could you mention what MCID is?
Oh, MCID is minimal clinically important difference. So for a pain reduction, that's about 30% reduction in pain. If you're looking at a NRS score, it's an NRS score decrease of 2, right? So if your patient has an 8, could they tell? Yeah, they could tell their pain difference if they got their pain down to a 6, okay? I can tell you if I did an injection and I got my patient's pain down from an 8 to a 6, they're not going to care. So they're going to want something more, right? So first, is MCID enough? I'm going to guess no, right? And then we have to ask, is there enough positive data that we can replicate to sell this to patients, right? Okay, so questions that I think need answering before I implement this in my practice are, how do I select patients, right? And what type of platelet, what dose of platelets do I need, okay? And then does the data support clear diagnostic criteria, clear doses that I can then implement in my practice and expect a percent relief or a reasonable amount of relief in my patients? So how do we select people? Their studies are kind of all over the place. I think the strongest studies do use provocation discography, like low pressure, relatively low volume propagation discography with concordant pain. Some studies just look at historic patterns of pain. So are you having anterior column pain, much like how we would select someone for BVNA, whether or not they have modic changes. Whether they not have modic changes is something that is debated as well and variable amongst the studies. Some studies exclude people with modic changes. Some studies don't comment, they just exclude people with modic 3 changes. And so I don't think there's been a consistent diagnostic criteria other than positive provocation discography to select someone for something like this. So unanswered studies, what specific disc phenomena do we target? Do we target certain types of motor changes? Do we only target annular defects? How much degeneration in the disc is too much? Is it like Furman grade 5? Or do we want to target lower grades of degeneration? And then do discograms actually have prognostic value, or are they just diagnosing disc pain? So the difference between just diagnosing it is if it hurts and it causes pain, well then you have a diagnosis. But if it hurts and it causes pain, does that then predict a positive response to PRP, which would be prognostic? So there have been several systematic reviews just in the past 4 or 5 years. I picked 2 of them. And yes, I cherry picked some of them, but the reason why I cherry picked one is Byron Schneider with the Ipsos group, they did a really good review in 2022, and good review as far as things that they focused on were clear diagnostic criteria, as in positive discography, and then they were looking at were there categorical data presented that they then could glean more from. Yum et al.'s the most recent one. I picked this one because it was the most comprehensive. So there are several systematic reviews that didn't include all the studies that Yum had, but Yum included all the studies from all the other ones. So I eliminated all the other ones and focused on really these 2 systematic reviews. So to help us answer these questions, like what dose do we need to use, right? And so of their studies, they had 4 randomized controlled trials, 5 prospective and retrospective observational studies. Everything else was case series or case reports, okay? So one study had 1.5 billion platelets per milliliter. Unclear how many mLs they injected in the disc. Maybe it was 2, maybe it was 3, so maybe they hit 4.5 billion cells, I don't know. Decade it out, had 700 million to 1.4 billion. The important thing about this study is this was PRP releasate, which is not well described as far as specifically what that is in that study. My assumption is that it's platelet lysate, meaning that all these factors are released and then injected. Zelensky, unknown. The study that Dr. Tiwari referenced, as far as the placebo-controlled trial, unknown. Okay, maybe 3 to 5 times baseline whole blood counts. Going further, I mean, this one on Zhang et al., they documented 1 billion plus or minus 900 million. So either it was like less than whole blood to full PRP, right? And so I think the point is, without just going like detail through all of this, is that it's all over the place, and I don't think that we know. Okay, if you have kids, you know what this is from. And so if we kind of zoom in on some of the studies, some of the RCTs that are commonly referenced, and we go back to, this is the same table, except I zoomed it in so you can see that, okay? So the way I did it, you can see the numbers. That is one thing.
It's not that I did that.
So when we see these numbers, and we look at current pain, and we look at baseline, for those of you in the back, this is 4.74, okay? And when we look at 8 weeks, This is 3.09. This is less than MCID, okay? And it's less than 50%, okay? So it's not also statistically significant, but I would argue even if this is statistically significant, it's not clinically significant, okay? And that's where we come in with best pain. Best pain at baseline was just under a 3, okay? Best pain at 8 weeks was a 2, less than a 1 point change. I don't care that it's statistically significant. It's not likely clinically significant, okay? So this is a trial, and if you read their conclusions, it sounds really rosy. When you look at their data, I'm not super excited about it, okay? This is pulled from Byron Schneider's RCT, and one thing that I'm not RCT, excuse me, systematic review. And one thing they did was they were looking at what categorical data was available. And so they presented this NAS patient satisfaction score with a responder rate of about 56%. So 56% of people were more likely than not satisfied with PRP treatment. Well, that's important, right? We want our patients to be satisfied. But I also didn't know what the NAS questionnaire was, so I looked it up. So if you scored a 1, you were very satisfied with your therapies. That's really good. We want patients to be satisfied. Even if their pain score wasn't super reduced, if they were happy with their therapy, that's a good thing, right? And then 2 is they were underwhelmed, but they'd probably do it again. Okay, so these people are lumped in, and we don't know how many were a 1 versus how many were a 2. So they're somewhere between really satisfied and meh, okay? So I don't know if that means anything to me either. Okay, the next one, this is fully in my favor here, is the Shepherd's review. It's not only the biggest RCT of 89 patients, they assume they use 1.5 billion cells per milliliter. If I'm going to be critical of this study, they're just assuming it based off of what they're told from the manufacturer of the machine, is what I'm guessing. It's not exactly described other than this machine produces this many platelets. When you look at other studies that are critical of his study, they mention that platelet count. But again, how much are we going to criticize it? Because every other study is different. And they also criticize the exclusion of modic changes. But again, we don't really know what the significance of intradiscal PRP, whether someone has modic 1 or modic 2 changes. So I'm not sure that that's a fair criticism just yet. Maybe it will be in the future, but I don't think we have enough data to know right now. And when we parse out their data, they have 48% get MCID on the NRS, 50% get MCID on a functional scale. So I mean, that's okay, but there was really no statistical difference in control, okay? And when we look at average pain, they're getting, PRP is this red line, 6.3 to 5.3, okay? This is, average pain is not significantly reduced. So they essentially concluded that for their study, intradiscal PRP compared to placebo in the largest RCT didn't make a difference. So average pain release was less than MCID, and it's unknown how many patients actually got 50% relief. So what's that actual responder rate of 50% or more? We don't know, okay? So this is a study that Dr. Tiwari referenced. And again, this was another study where their conclusion was very pro-PRP. They said, hey, this is really promising. And so it was a 3-arm RCT, just to review it a little bit again. They used trigger points versus PRP versus bone marrow. And again, we're going to focus on PRP, not bone marrow for this. But all the trigger point group crossed over. All the trigger point groups crossed over. They were all dissatisfied at 3 months anyway, so they crossed over anyway. So I have no problem with that. And then their preparation, we don't know what the counts were, but they took 60 mLs of blood and got 7. So reasonably more than 5 times concentration, I guess, you can assume. Okay, no categorical data provided, which is concerning. They did exclude severe discs and modic 3 changes, which I think is important. I mean, it guides us a little bit, right? So if it is really, really positive, maybe if I'm choosing patients, I'm not going to do modic 3 discs or discs with like really high Fermi rates, okay? And so let's look at this. And so the problem is we didn't get categorical data. So I have to like zoom in on this and say, okay, maybe this is 6 3/4 here. Maybe this is 3.5. So that's where I got these numbers from. I just looked at their graph and guesstimated, okay? So if we look at the results, pre-pain was almost 7, post was 3.5. So this is MCID. This is not exactly 50% reduced though, okay? So how many patients are really, really satisfied? The graph looks good, but it's not a 50% reduction. How many patients are satisfied? This is where they crossed over, right? This yellow line is the placebo. They're all dissatisfied, right? They're like getting less happy, okay? And then the BMAC and PRP, they're getting more happy. But what does that mean, right? So pre, they're around 2.4, post they're 1.6, so a little closer to the meh than the really satisfied, but kind of improvement. But I'm not super excited about that either. I want my patients to mostly be satisfied. I want this closer to the 1, right? So although some positive spin on this, it's still not selling me necessarily that I need to do this for everyone. And then this is the most fun trial, the Zelensky trial. They took 26 patients with leukocyte poor PRP and they compared it to saline. No, we don't know what the platelet concentration is. They also did 50 mL to 6 milliliters of PRP, so maybe it's reasonable. And they just had to quit the study because people weren't getting better, okay? So there's just, they essentially that we should abandon PRP, and they said maybe we should try something else, okay? So what questions do we still need? And did like any of this data help us answer any of these questions? Well, how do we select them? I guess generally with provocation discography, it seems reasonable, but it's unclear still how severe or how mild the disc degeneration needs to be. I would also say that it's unclear if like someone has an acute annular tear and you treat that within 3 months of PRP, is that going to respond better or not? I mean, these are all so many, I think, reasonable questions to ask that we don't know the answer to. What dose of platelets are needed? I mean, I don't know. And then does the data support improvement in pain and function? I think no, okay? Okay. I know you had some improvements in function, okay? And I know some patients were trended towards satisfaction, so maybe there's something there, but right now, no, there's not yet, not in my opinion. Okay. All right, we just kind of wanted to open this up. If anyone had any questions, do you have any thoughts?
Well, okay, so I was given the harder task here, okay, first of all. So I think that just to add to a little bit more of nuance to what Dr. Vallabh had mentioned here, and something that he and I had discussed quite a bit as we kind of created this talk and obviously are in front of you today, is, you know, all of this data is this data, and we kind of can make your own mind up about it, but I think that what we would like to share is that, you know, this is not necessarily a conclusive talk as to whether we're pro or anti-PRP. I think that it's important to perhaps have this discussion with patients that this treatment does exist, but to provide the full context of what, you know, the promise is. Many of you may have driven down the highway and seen advertisements for PRP for everything from hair to, I mean, I don't know what, you know, cosmetics, everything. People are using it for all these types of things. As you can see, the data, you know, based on what we've presented here is predominantly that it may not be a very effective treatment, but also, on the other hand, that it may not be nothing. So you know, is it a conversation worth having with your patients? Perhaps certainly so. Could there be patients that are in a sliver of criteria that there may be a role, some utility to provide this treatment? Certainly, I think that we both agree that it's perhaps a conversation that you could have. But on the other hand, the more objective data is as we have sort of presented here today. But again, as everybody said, you know, we'd love to hear thoughts from the audience if anybody, you know, has anything that stands out or they'd like to share. Not all at once.
Yeah, I just have one thing too. Like as far as what Dr. Ansami was talking about de-utilizing treatments. And sorry if I didn't say that correctly. But is, you know, patients are, you know, patients come to my practice. We just opened a practice in the suburbs, and so now we get some patients asking, like, should I get stem cells? Should I get PRP? And all these other practices in our community are doing them. Chiropractors even are doing all sorts of stuff to patients. And I get patients who spend $10,000 or $15,000 on something, and they're very dissatisfied, and they come to me, and it's like facet pain or something simple, you know. And so I think the question of appropriately using injections is really important. You know, now almost a decade ago, when I interviewed for pain, one of the big talks was about the overutilization of what we do, and it's really good to be innovative, and we want to be on the front end of as much as we can, because we all want to help people. And when we see emerging technologies that could rebuild it, I mean, how many patients think they have a disease when they come to you and they have disc degeneration, and you're explaining that it's not a disease, right? So in those scenarios, how much do we need to regenerate something that is a normal part of aging? I think if you look at some of the knee data that's really promising, and you can help with pain and function, and we all want that for our patients, I think, and if we can repair T2 signal loss in a disc, and you missed some good studies there that they're small, they're like case series, but show that maybe there's some disc level change in signal. We want that for our patients, but we also have to, I think, when it comes to the appropriate use, make sure that we are educating our patients. So, I mean, you can almost do that to a fault. I have one of my mentors is an anesthesiologist. He's very charismatic, and that makes patients feel better because the more charismatic you are, the little bit more of a placebo effect you have. And I'm in my clinic telling them, you know, you're getting a lumbar RFA, you got 100% improvement, so you have like a 70% chance of getting better. I mean, that's like the total opposite. So you gotta find, you have to find some in-between ground of like helping your patients get better, but then also educating them on what is the actual evidence. So if I had a patient come in and we have a PRP machine in our office, and they were asking me, you know, should I get PRP in their disc? I would like go through some of this evidence with them, not with a PowerPoint obviously, but we talk about the limitations, and if they want to spend their money, we do it as safely as we can and we see what the outcome is. But I think part of the appropriate use of it is really making sure that your patients are truly informed about the risk or lack of benefit of what they're paying for.
And then the final just little tidbit that I will say is that, you know, this talk is focused specifically on the use of intradiscal disease, which in our research we found is probably the most controversial or the most kind of back and forth evidence, so to say. But I just want to mention that, you know, a lot of people are using this for sacroiliac pain, for facet-mediated pain, and that's a conversation for another time.
This is like a can of worms.
Yeah, exactly. So anyway,
You know, generally speaking, after a debate, you kind of have a show of hands as to who won. But before I do that, and I'll do a variation of that at the end of this, but before I do that, any questions from the audience that might allow all of you to come up with an informed decision as to who won the debate?
I give this one. That's mine.
Yeah, you get it.
I feel like this debate, you know, a lot of people have a lot to say, but like debating who's worse, the Browns or the Bengals. A lot of people have a lot to say.
The Browns.
But a lot of people have a lot to say. But give us, as like an everyday PM&R provider, what's one practical tip that we can use to help manage these patients as they come in? Like, what would you do if they come in asking for PRP specifically for this?
I mean, honestly, I would just go through the evidence, and I would kind of show them the possible benefits of it, and then the possible limitations of it, so that they can make an informed decision. If I thought something was harmful, right, like if I truly believe that doing an injection in the disc is going to damage the disc 10 years from now, which I think is also a controversial kind of thing, and there's things on either side of that, then I wouldn't do something that I thought could reasonably harm the patient. But if I thought that a therapy was relatively safe and of limited harm, you know, as far as like relative to everything else we do in patients' spines, then I will inform the patient as much as I can so that they can make an informed decision. You know, I think that's important. I honestly think even when you're doing just an epidural injection, informing a patient. I get so many patients who come in and just like, oh, so I can get one of these every 3 months, right? It's like, well, I mean, yeah, but is that a really good long-term strategy? You know, you know, if you're trying to delay surgery till you're retired, is doing an epidural every 3 months till you get osteopenia at the surgical area a really good long-term strategy? So I think it's just in general educating patients so they can make an informed decision for themselves, especially if they're paying out of pocket for something.
Yeah, I mean, I think the part that you're hitting hard, the patient education side is, you know, anytime we're seeing patients, obviously, some of them, they have to meet the right criteria for this. So, you know, if they failed everything, what's the alternative, right?
Yeah.
Ischemic pain, that's the point, right? I think that's kind of where you're coming from is, what is the alternative? The alternatives aren't great right now. So I think that's kind of, so even though MCID, you know, 30% from a pain score of 6 down to a 4 is not significant in terms of clinically we're looking at it. For them practically, if they're still down from a 6 to a 4 and it's an option, what's the alternative? If they can stay at 6, they've done all the other stuff.
Yeah.
What are the other options right now? You're not gonna fuse them at a young age, right? You're not gonna do it like some of these guys do it,
Yeah.
right? So they're gonna go seek care other places, they're gonna seek surgical consultation, and the surgeon's gonna, fuse them or something like that. So we have to look at that bigger picture. The education side is essential, but I think, we do need more data, obviously. And the second question is, so you've done this? Or
No,
not?
so I came into this thinking, I want to do this.
Okay.
I want to be able to offer this to patients. I work in a big orthopedic clinic now, and so we have a PRP machine. And so my goal in looking into PRP data was, how can I incorporate this more into my practice, and I want to do this. I came into this thinking, hey, I want to do this. Let's see what's up with this. And so far, nothing has convinced me that I should do this yet. Yeah.
To that end as well, I mean, more and more patients are asking about these therapies, as you kind of illustrated. We see, again, the billboards and everybody, it's on Facebook, TikTok, whatever people use nowadays. So that's one of the purposes that we wanted to have this talk on this matter, is that it's something that's likely for those of us who do this day in and day out to come up.
And patients are going to look at like Google searches, and if you Google search this and you get a Google AI response, patients think that they should get this, because Google AI responses just looks at those, like they're not parsing the MCID, they're just looking at the conclusions. So if everyone writes positive spin conclusions, then the AI algorithm is going to tell patients that they should do it.
Just to the last point regarding what are the options, and it's not nothing. I recently got introduced with this new practice one, the Intracept, and the proposition behind that is a lot of the pain from what has been called discogenic pain is vertebrogenic.
Yeah.
So
This
from
is
the end plates
another
themselves.
one.
So you find, the motor changes, you have to have the motor changes. Then if you go and you burn that intervertebral nerve, that's
Yeah, that's much better.
Yeah.
So there's other options, but,
Yeah, I know we could have kind of explored that as an alternative, but I felt like that was a whole different topic. And just like how much pain, like if you have an annular tear, is sinovertebral disc-based pain versus if there are motic changes. I think that's something that we don't know. I think in my head, coming into this, I thought, man, when we're doing intradiscal PRP, we're gonna pick out the acute annular tears or the subacute annular tears and try and heal those in like mostly young healthy patients without major disc degeneration. That was what I thought when I was going to look into evidence. I was going to find like well-selected patients who did well, and I just didn't.
All the way in the back standing.
I think something we all need to be thinking about is what is the utilization of Intercept, PRP, IDET, whatever. What is the utilization of these fancy procedures outside of places where physicians don't gain direct monetary benefit from doing the procedure?
Yeah.
Like, I'm half Dutch, I don't hear of any of this stuff happening amongst my cousins who are physicians in the Netherlands. To be fair, the normal treatment is paracetamol, but that's another story.
That Shepherd's negative study was a Netherlands study, actually, that was very negative about it. Appropriately so.
I'm curious about the use of pain scale as the primary outcome rather than function. That's a pretty significant change historically from what we used to do as physiatrists. I think it also drives, to the point of reimbursement, I think it also drives the challenges that sometimes we face in getting reimbursement, because insurers, I think rightly so, don't reimburse for subjective pain improvement, but do reimburse for objective functional improvement. But moreover, I think in talking to a patient, I think rather than saying the goal is to reduce pain, it's much more helpful to say, my goal is to play basketball with my kids, or my goal is to walk around the block, or whatever it may be.
I think that's why we're all doing like oscillatories on everybody now these days, right? So we get a different functional.
Yeah, we do promise physical function measures but I think you're right. You're trying to focus on physical function, and I gave you this because your studies did show some improvement in physical function and not pain. And when there is improvement, and you'll see this in studies in other areas where there's some improvement in physical function but not pain, I think that's probably a really promising study, because one of the two things that we need is getting better. I think that really strong therapies though get better in both domains. Like, so when you look at the responders for basivertebral nerve ablation. They get better in both domains, not one more than the other. So I agree with you, but I personally, I like to see both for my patients.
You like, but the part of it, I guess the follow-up is something I tell my patients, I think that it is ponderous sometimes, but it's really true. My goal in treating patient isn't to improve pain, or actually this way, patients always come with you, they want their pain better so they can get their life back. But that's not how it works. I haven't seen them in 30 years. What happens is they get their life back and then the pain goes away. And this is encouraging the opposite. If you're measuring the pain first, not the function, you're doing it backwards.
That's fair. That's a fair
an excellent
criticism
point.
of the way we
Yeah.
looked at it.
Go ahead.
I just want to make a comment in light of what he was saying. Like my organization, we're starting with the registry, the PM&R registry, the spinal study, plug for the Promise 29 for everybody. Swestry, if the person misses two answers, like they almost never answer the sex question, for example, the Swestries are pretty much useless from a studying standpoint. Promise 29, they can skip half the questions and it's still statistically valid. So plug for everybody. If you get Promise 29, go look it up. It's free.
We use the Promise
It's
29 as
Epic. You can have it as a module. It's actually an adaptable module of Epic. So if we all want to be physiatrists and think about adding quality of people's lives, then we should be thinking about function and their quality of their life and how they're living their lives. And that's a statistical measure that can be used by all of us, even in just regular clinical practice.
So I think in general I agree. We just at OSU we spent probably the last 2 years just integrating PROs into Epic. We work with a certain company, not a PM&R though, to do that. Yeah, we're also doing Promise 29. And I completely agree. We need this additional information, but just beyond research. I think just standard of care, as far as like how patients are doing. I think one nice thing about working at a big university is all our physical therapists are doing ODIs on patients every visit. So I've had several conversations, to your point actually, where patients feel like therapy was useless and their ODI went from 65 or whatever to 30. And I was like, no, you got better. And I'm just trying to convince them that they got better.
Well, a vigorous debate. Thank you so much. Wanted to also plug for the foundation, whose mission is to advance physiatry through research. So please consider donating and contributing so that we can continue to do those things. And finally, to figure out who won the debate, I'm going to use a version of the Net Promoter Score. Net Promoter Score is used in industry to figure out how many promoters versus detractors somebody has. So fully acknowledging that we might see a vast majority of you in the middle. So if you're not doing PRP right now, you might continue to not do it. Or if you're doing PRP right now, you might continue to do it. But who are on this side that if you are doing PRP right now, that you will stop doing it? Anybody?
No one was doing it to start.
Yeah, I don't think
No one was doing it to start though, in my defense.
Okay, so if you're not doing PRP right now, how many of you are going to start doing it at the end of this debate? All right, so I guess the Net Promoter Score is a solid 0.